They found that if people increase their score just by 5 points on this 21-point score guide that we're going to look at in a second, they could reduce their chances of dementia and stroke by 60%, up to 60%. And so that's a major thing. We're talking about adding up all those percentages in midlife of improving on some risk factors. If you can increase your score, and we're going to look at how can you increase your score. What bringing blood pressure down from what to what gives you a point, and so on. So I'm going to do this live right now. I'm going to check my score. And I've done this before, so I'm a little embarrassed, but my score is not great.
What is it?
Well, it's 13. I'm just going to tell you right off the bat, but let's go through it.
So I'm doing it now.
Welcome to the Better Brain Podcast, where we talk about everything brain health for anyone who has a brain or knows somebody who does and wants to make it better. So today we're going to talk about all things dementia, from the reversible causes of dementia to the irreversible, progressive, neurodegenerative, and all the risk factors of dementia, for early onset or young onset dementias under 65 to late onset dementia over 65. And I think you're going to be surprised at how much of the dementias, what percentage of the dementias are preventable. And then we're going to wrap all that up, synthesize it down to some accessible, actionable, and accurate takeaways, as well as a brain health test. We're going to take it with you and see how we do, see how well we're set up for brain health today and over the long haul, and to protect us against aging and dementia.
I think what has me most excited about our conversation today are the modifiable risk factors for dementia. I think some time ago, we probably thought that getting dementia was inevitable. People used to refer to it as just being senile or senility, right? But from very recent literature and some pretty groundbreaking studies, we've been able to determine that there are modifiable risk factors, and they can significantly impact someone's trajectory towards dementia. And a really interesting take that came out of these papers is that even if you do end up getting dementia, working on these modifiable risk factors will improve your quality of life years during that diagnosis and lessen the frailty years while you have that diagnosis. Yeah. So that's when it gets into the whole health span topic.
Yep.
Yeah. So.
Yeah, I mean, I think nowadays we're redefining what's important. It's not just living longer, but it's living a quality life longer, more quality in your years. There's been some great books, some great podcasts, some great influencers that talk about the topic, and are putting out really interesting and important work on the topic. But today, I think what we need to do is lay the groundwork. What is dementia? How big of a problem is it? And what are those modifiable risk factors? How do they stack up against some of the things that we can't modify, like our genetics?
Right. So it's clearly a big problem. I think worldwide there's 50 million people that have a diagnosis of dementia, and that number is expected to go up to 150 million people by the year 2050.
Yeah. Along with, obviously, the
aging population.
In aging population.
Yeah.
People living longer and the growing population.
Right. But that means that right now we're at a crossroads.
The burden of disability from dementia is increasing no matter the cause.
Right. So considering that, these modifiable risk factors, I think, are especially important.
Yeah. Let me just kind of put it into perspective. I just have a few stats to kind of gain a sense of gravity around the weight of dementia. 10 million new cases a year, 1 new case every 3 seconds. Thinking about age as a risk factor, which is probably the biggest risk factor, 1 in 10 people over the age of 65 will develop dementia, and 5 in 10, 50% over the age of 85 will develop dementia. The risk of dementia doubles every 5 years after the age of 65. And now thinking about that big number that you put out there, 150 million, almost 3 times the amount of people living with dementia in 2050, that's a massive weight on society, on families, on the world. And it's become the leading cause now, brain diseases, of disability and worldwide disabilities worldwide, overtaking cardiovascular disease. And so we need to be thinking about what are those risk factors. Can we mitigate some of this disability for the individual? I mean, we're doing this in clinic every day, but also for our future.
Right. So You're the specialist when it comes to neurobehavioral neurology. Why don't you lay the groundwork for what dementia is?
Yeah. So it's a good point, good question. It might seem basic, but I think there's lots of details in here that at least patients are getting wrong every day, and it really matters. It really matters what we call dementia. And so if you think about it this way, dementia is an umbrella term that corresponds to anything that can cause a dysfunction in everyday life related to cognition. So one or more cognitive domains like memory, visuospatial function, motor function, coordination, processing speed, language, any of those go down to a point where it's causing disability in everyday life, where you're not able to do your activities of daily living, like take care of yourself, or some of your independent activities like banking and driving and things like that. That's what we call dementia. And so that could be everything from Alzheimer's, which is the classic thing we think about that we're all worried about, but to things like depression or post-traumatic stress disorder, which can cause cognitive dysfunction to the point where it's disabling. And so dementia is an umbrella term. And the way I like to think about it is in two buckets under that umbrella. One is reversible causes of dementia. And so depression, post-traumatic stress disorder, while those are very difficult to treat, those are not neurodegenerative, progressively worsening diseases. Those are, to some extent, reversible. And so the cognitive dysfunction related to those conditions, as well as many others that we can talk about, can actually improve with treatment. Whereas the other bucket of dementias are the neurodegenerative, irreversible, progressive dementias, where neurons are dying progressively over a period of time when that condition starts. And those are, at this point, irreversible.
Yeah. And I think that leads us really well into how do we diagnose it, right? Because that then means that the dementia diagnosis must be a clinical diagnosis, right?
Yeah.
And if we're starting to think about, well, there's some things that are reversible versus some things that not, it's a kind of clinical presentation.
Yeah. No, it's a good point. I'll just say, for clarity, the progressive or neurodegenerative causes, the classic one is Alzheimer's, dementia with Lewy by Parkinson's, related dementia, frontotemporal dementia, just to give you a sense of what that other bucket is. Going back to the reversibles and our approach to making a diagnosis, first we've got to rule out reversibles. Right. So big buckets there, vitamin deficiencies like vitamin B12, thiamine, folate, alcohol use and other substance use disorders that can affect cognition and cause disablement in everyday life. Things like sleep apnea and other sleep disruptions, mood and anxiety disorders that we've talked about already, hormone dysfunction, thyroid disorders, for example. These are under the classification of reversible. So we first look for all of those as a cause of an individual's cognitive difficulties. Maybe they have memory difficulties, vision difficulties, visuospatial, trying to navigate, getting lost. And so we look first for those. And let's say all of those checked out. We get some blood work, we take a good clinical history, we do a physical exam, we're looking at their medical records to understand what they've been through. If there's some looming other medical problem that's at hand, maybe they have hypertension and it's causing blood perfusion problems, and that's causing cognitive dysfunction. But with good treatment, that could reverse. Maybe it's diabetes, a cardiometabolic problem, and now that's causing a mismatch of energy and misuse and inefficient use of the brain. So that's causing cognitive dysfunction. We improve that, their cognition could improve. And so those are the reversibles. Those are some examples. It's obvious how you would test for some of those, and then how you would treat. In fact, I've had a patient recently come to me in the movie industry, and kind of the production. He said, "Look, I used to be able to build the set, take down the set, and do all of the legwork, no problem, easy. I remembered everything, remembered everyone's names, and suddenly, after I had some type of illness, maybe it was COVID, maybe it was flu, wasn't healthy enough to go to the doctor, I couldn't remember anything new, and so it would be anterograde amnesia. I would have conversations, I would have appointments coming up, I would have things I needed to do, things I was told to do, and I couldn't remember." And so I looked at his risk factor profile. I looked like what labs has he ever gotten, what checkups, what primary care visits. Turns out he had a diagnosis of prediabetes years ago, hadn't been to a physician in a long time, finally got back to a physician, got a bunch of labs, had diabetes, high cholesterol, high blood pressure, and a number of other things that potentially could be treated. And so I said, look, let's get aggressive about this. Use your primary care doctor as a jump-off point to quarterback everything. And he did everything, and his memory got way better. Yeah. The fact of the matter is, because of those risk factors, he had a stroke in this one part of the brain, in the thalamus, the mediodorsal thalamus, that knocked out part of his memory circuit for making new memories. Yeah. However, it was one side. The other side was still functioning, and with improvement in those risk factors, those reversible causes of, in this case, cardiometabolic dysfunction, he was able to improve his memory and get back to work.
Yeah, I think great story. And, also these modifiable risk factors that we talk about, they could be prodromal. And I think it's important to note that if you optimize treatment for these modifiable risk factors and there's no improvement, then potentially these things like psychological symptoms like depression could just be a prodrome of something.
Let's unpack that. So what do you mean by prodrome?
Well, we know psychological symptoms are, significantly associated with certain dementias.
Right.
And sometimes even they are the presenting symptom.
Exactly. I think that's where really we need to, kind of get clear on, because while psychological disorders, mental health disorders, can be a risk factor, which we'll talk about soon, they can also be part of the condition itself.
That's right.
Due to the mechanism of progressive degeneration that's occurring in the brain, that can cause an individual either to have emotional circuits be affected and their emotion and their coping and their capabilities change in that respect, and or they could be very aware of their difficulties, as is common in Alzheimer's, and that can cause some anxiety, some mood disturbance itself, and would be in that case a prodrome or kind of a foreshadow of another condition kind of looming and percolating.
Yeah, it's interesting to think about how far are we willing to extend the whole prodromal theory, right? When you're talking about diabetes, and you've heard of dementia is now referred to like the type 3 diabetes. It's interesting to think about. What do you think?
Yeah, well, so it's a good question. I think we should table it for the risk factor conversation, because I think prodrome really is a sign that something's happening already but hasn't taken form in the typical presentation. And so the typical presentation, let's say, of the flu is runny nose, cough, and upper respiratory symptoms. But the prodrome to the flu is achiness. Achiness can be caused by working out the night before, having a bad night's sleep, eating something bad and getting inflamed. So the achiness is the atypical foreshadow, but due to the immune response for the infection that is yet to present in a typical fashion. So I think prodrome is the beginning of an illness, and has to do with the illness itself, rather than a risk factor that is in some way causative in either directly or indirectly of the condition itself. Yeah. And so when we talk about the risk factors, I think those are all, way before prodrome and have to do with instigating the illness itself.
For the paper that we're going to talk about, they actually mentioned that they looked at depression. It was a risk factor for dementia. But in their paper, they recommended that moving forward, future studies look further out than what they looked at, right? Like looking at depression.
Within 3 years of a dementia diagnosis.
I thought it was 5. Yeah. Whatever. Multiple years out from the actual diagnosis.
Yeah. Well, in their study, within 3 years, it just was too close to make the call. Yeah. But looking further out, 10 years before. Yeah, totally.
Yeah. Okay. Let's keep it moving.
Yeah.
Yeah.
So we talked a little bit about kind of the reversible causes and going after a workup for cognitive symptoms in that way first, making sure that we're looking for these things that can be treated, that can off the bat improve symptoms. And it might take days, weeks, or months, but these are worth checking out. And I'll plug one of the reactions that we'll have to do at the end, the Bredesen method. The Bredesen method made its name off of a book of cases that found B12 deficiencies and other things that could be reversed with vitamin supplementation, for example, in this case, and said dementias are reversible. But that's not true. Dementias caused by reversible mechanisms, like vitamin deficiencies, are reversible.
Reversible dementias are reversible.
Yeah. Right. Yeah, but irreversible progressive neurodegenerative ones aren't yet reversible. There's no curative agent at this point.
I think, well, that's getting into understanding the nuances and the differences under this umbrella term of dementia,
Yep.
which, you helped us do between neurodegeneration and reversible.
Yeah. So then if we were to go down the standard route next and say, okay, we don't think this is a reversible cause.
Mm-hmm.
And in fact, what we should really do, we should take into account normal aging.
Mm-hmm.
Normal aging is a thing.
Mm-hmm.
When the brain ages normally, it loses neurons.
Mm-hmm.
It loses capacities. It loses it in a certain way that is somewhat different than the classic dementias.
Right.
Just to kind of give you some examples, when we think about normal aging, memory's affected, cognitive skills are affected, language is affected, attention is affected, but it's all more mild and not of a classic pattern that you would expect with an Alzheimer's-like condition, for example. So memory. In Alzheimer's, it's affecting everyday memory, recent or memory that is what a lot of people would call short-term.
Mm-hmm.
Things you just learned, talked about, ate, did, events, declarative things that you're doing, episodic things that's going on in everyday life that you're forgetting from one moment to the next. You might repeat yourself in a condition that has Alzheimer's and not know that you've just repeated a story or a question. Those would be classic signs of the extent of memory deficit, the extent and kind of type of memory deficit in Alzheimer's. But memory decline with aging is common. It happens. It's a forgetfulness. It's a tip of the tongue phenomenon. It's searching for that word or that thing that we did. I can't remember in the moment, or that name of that person, or what is supposed to. Why did I come in this room in the first place? What was I going in the refrigerator for? And it just is not there in the moment. But you leave the area, and boom, there it is. You come up with it eventually. That's classic for memory decline as a factor of normal aging. Whereas if it's gone, the memory for that thing, especially short-term things, recent things that just happened, is gone. That's a little bit more worrisome. That would be the difference there.
Can you give us, let me interrupt you, give us a little bit, something a little bit more concrete instead of it's gone versus it's not gone, you kind of get it back.
Yeah, so let's say I've got some things I wanted to do today, talk to my wife, and we agree that, I should go shopping and grab milk for the baby and a few other things to, make dinner tonight. And so I leave. I didn't make a list. And I get to the grocery store. I'm like, oh, my God, what was I supposed to get? Obviously, milk, I'm there. But what did we want to make for dinner? Was it fish? I can't remember. And then I just kind of rack my brain a few more minutes. Maybe let me go get the milk. I get the milk, and then I'm like, oh, yeah. Okay, it was, fish and salad and some other things that we're going to get. Mm-hmm. And that would be normal. That would be normal for a distracted brain with a young child who's got a lot on their plate. That would be normal for normal aging with no distractions. It'd be normal for somebody who, was dealing with trauma or chronic pain or something like that. Distractions steal resource from the frontal lobe, being able to handle those kind of demands of everyday life and retrieve memories that were stored normally.
Yeah.
But when the individual, let's say, goes into the store and completely forgets the conversation ever happened. Wait, why am I here? Why did I even come here? I don't remember. And goes home. And
doesn't grab anything.
Is reminded, maybe grab something.
Maybe grab something because they're there.
And goes home and is reminded by, let's say, his wife, honey, did you get those things that I asked you to get? Oh, no, I didn't. Mm-hmm. And would have forgotten the conversation. Mm-hmm. And so that would be the difference. It's gone versus it's recoverable. Mm-hmm. With some skill and tactic and decreased mitigation of distraction.
Texting the wife.
Right. Well, you could deploy that activity, and that would be a completely reasonable workaround, which right. In cases of dementia, you should be able to use.
Right.
I just hit a few more, just because I think it's interesting to think about normal aging versus dementia. I think
it's
everybody wants to know that.
It's important because I hear this all the time especially with my concussion patients and my PTSD patients. They complain about these things very similarly, but I don't think it's to the degree that you're trying to communicate, which is, I have no idea why I'm here, and then you just go home because you don't know why you're there. Right.
I would argue, though, a sophisticated, I'm now putting myself in that category, but a sophisticated neurologist, somebody who's thought a lot about this and seen patients on both sides, reversible and irreversible, should know that it's a severity thing, a severity of the issue. Mm-hmm. The memory for that thing is gone versus it's retrievable with effort. That's the difference between something that's reversible or due to aging, normal aging, versus dementia. It's gone in dementia, specifically Alzheimer's, but it's retrievable with effort in something that's reversible. But a lot of patients, I think, would argue, no, doc, it's gone. Right? Yeah. But I still don't feel that, based on the clinical scenario, this is a neurodegenerative phenomenon. And so beyond severity, you're looking at the pattern.
Right.
Okay, is it that they're just forgetting the things that they just heard about, just experienced, just learned, just wrote down, and don't have in front of them, which would be classic for a neurodegenerative phenomenon to the hippocampus, for example, in Alzheimer's, but would not be classic for something that affects the frontal lobes, like sleep apnea or depression or anxiety or post-traumatic stress. And so in those cases, it would actually be, doc, I can't remember a lot of things. And in fact, it's not just recent things. I forget things about my childhood. I forget things about, last year. There was a whole period of time where I just have a complete blank of where I was and what I was doing. And that's atypical. That's actually pulling from all different types of brain regions and storage centers all throughout the brain, rather than the use of the hippocampus discretely, which has a vulnerability to Alzheimer's pathology. And so the pattern in that case tips me off. We're going beyond short-term or recent memory, episodic memory, into other categories of memory that, if the brain doesn't have resource, if the brain is overly distracted or overwhelmed with emotion or mood or anxiety disturbance, that could cause these major disturbances. The severity could be high, but the pattern is just different.
Yeah. Certainly we're speaking to neurologists and other healthcare professionals on this thing, but I really want to be able to communicate the differences to people that might not be in the healthcare field, that might not be physicians. Like, when should I actually be worried about this as it relates to a neurodegenerative condition? Yeah.
Well, I think if you're having any problems, you should be concerned enough to go to somebody.
Right.
So it's hard for me to say, hey, because of the way I see you and the way you're functioning in everyday life, that it's not a problem. I've never seen a patient where I've been able to pull that off. No, it's not a problem. You're doing fine. Well, doc, I don't feel fine, and you didn't know me before. And where I functioned before was very high level. Yeah. Where I'm functioning now, even though I'm acing these tests, is not where I used to be, and I don't feel normal.
Yeah.
There's nothing I have nothing to argue in that case. And so I wouldn't make that argument. But I would try to address the pattern of difficulties that they're having to see if it fits a neurological pattern rather than something that's more global. A global pattern would be like, it affects not just short-term memory, but other forms of memory, remote memory, working memory, trying to hold things in mind for periods of time. Yeah. People with Alzheimer's could do remote memory, right? They can still play the piano if they learn that, or rote memory in that case. They could still do procedural things like brush their teeth and shave their face and make a meal and stuff like that. Learning something new, though, no.
Yeah. Let's circle back to age-related degeneration of the brain or volume loss. I think it's really important because I have tons of patients. We do an MRI of the brain, and in the report, it's age specific volume loss of the brain. Yeah. And they get the report before they see me, and they come in freaking out, like, why is my brain shrinking? And they're like 75 years old. I think that what's important to note is that degeneration of the brain happens naturally. Right, and we see that on MRIs of the brain.
Volume loss, for sure. Neuron loss over time.
Would you not say the term degeneration?
I don't know if I would. But I would definitely say volume loss. You're losing neurons, and over time, that volume loss is observable. But again, we go back to pattern. In that case, what I would expect if this was normal aging is proportionate for that person's age. There'd be volume loss, but it'd be global. Yeah. It'd be across the whole brain, not in a pattern that fits a circuit. Right. Which I'll just throw it out there now. The phrase if it fires together, it wires together, meaning if there are brain cells that are firing together, active together as a team to perform a function like language, listening, comprehending, and then speaking to react to a conversation, that's a network. That's a whole circuit. Yeah. If it fires together, wires together, means it functions as a circuit, and it does that in a developmental trajectory over the course of experience and time. Right. But the next part of that phrase that we're learning in dementia, if it fires together, it wires together and dies together. And so it's thought now that dementias, or neurodegenerative forms of dementia, are circuit or network related dementias. They fit a pattern of atrophy that's specific to that neuropathology. So, for example, the memory circuits and visuospatial circuits that take up the temporal lobe all the way up into the parietal lobe are the ones most commonly hit by Alzheimer's forms of dementia. Whereas in frontotemporal dementia, it's the frontal and temporal regions. And in dementia with Lewy body, for example, it's the more parietal occipital regions that become atrophied. So those would have a specific pattern of atrophy, and depending on how far along they are, could be more severe atrophy than you expect for age-related neuronal loss.
Yeah, so I think that transitioned us really well into diagnosing dementia. So what I found interesting, and you've mentioned it before, is the fact that, on autopsy, neuropathological findings, so someone dies of a dementia that you would say is Alzheimer's, and you cut open their brain after they die, and then you see what kind of proteins were deposited in the brain. You'll see the Alzheimer's ones, but then you'll also see several other different kinds of proteins that correlate to different kinds of dementias.
You could, yeah. I mean, it's common to have more than one pathological process. And so when you're trying to make a diagnosis, you first do that clinical exercise I told you about, trying to rule out reversibles.
Right.
And then you move on to understanding what are the risk factors in that person's life that might actually make them vulnerable to a neurodegenerative condition, like a family history of neurodegenerative conditions, especially if those occurred in their family members at younger ages than 65. And that would be something that would be more concerning than after 65. Could be genetic factors, other exposures like traumatic brain injuries in their life, and so on and so forth. We'll talk about those risks. So I would assess them for those risks. And then I would look at the pattern of cognitive deficits. We talked a lot about that for memory, but there's patterns in language and visuospatial and so on that I would look at. Executive function like decision-making, multitasking, problem-solving, organizing, planning, and patterns of behavior. And that comes into play in a really interesting and devastating way in frontotemporal dementia, where behavioral graces, social graces are lost, impulsivity takes over, and inappropriate actions occur. And so you have to think about the patterns in front of you with clinical history, with a behavioral exam, and then with cognitive and a neurological exam to see if there's any physical features of the condition that has affected them peripherally. Right. Is there a stiffness, a rigidity, a stooped posture, slowed gait, tremors, and so on. And so once you take that whole clinical part of the picture into account, then you move on to biomarker studies, and that might be brain imaging, like a structural MRI. It might be functional brain imaging, like a FDG PET, which we can unpack in a second. It might be spinal fluid or blood testing or skin biopsies, for example, to get closer to a more certain diagnosis. But at the end of the day, right now, there's no neurodegenerative disease that we can diagnose with 100% certainty in life. We diagnose, at best, with probable certainty, a probable level. You can diagnose definitively, no, this is not a neurodegenerative condition, or it's likely, it's possible, or it's probable.
Yeah.
And then after death, on autopsy, when you look for the pathological proteins that are associated with each of these clinical scenarios, then you say, oh, you know what, their clinical scenario with the atrophy we saw in the brain imaging, with the memory difficulties we saw in their clinical history and on exam, that was due to Alzheimer's related pathology. But there's some strokes here too. And so you might say something like that.
I don't know if you mentioned it, but one thing that I wanted to highlight as it relates to clinical diagnosis is you're looking for a progressive deterioration in those clinical symptoms. I don't know if you mentioned it or not, but that's important, right? So like someone's good one day and then they come back 3 months later and they're a lot better in their symptoms. That speaks against a neurodegenerative process.
Except if it's dementia with Lewy body, or other way that said Lewy body dementia. That actually one of the clinical features is fluctuations in the symptoms. They're not going to be 100%, between fluctuations, but they could have good days and bad days.
So initially, you see that fluctuation, and then that fluctuation becomes less and less and less as the neurodegenerative process progresses.
I'd say the range of the
fluctuation
of the kind of return to a normal level of functioning changes. So it's more of a trending or progression of decreased function with fluctuations in dementia with Lewy body. And so where they once could have good days and look pretty good, kind of function and perform pretty well, they eventually no longer able to do that.
All right. So you mentioned genetics.
Yep.
And I think a big question, and what we're finding is that genetics is clearly not the entire picture. But what about the numbers as far as genetic contribution to dementias? The study that we're going to cover a little bit discussed that out of all the genetic factors that we've identified thus far for young onset dementia, only about 5 to 10% actually contribute to the diagnosis of young onset dementia.
Well, can be attributed to genetics itself. And so there are a handful of deterministic genes, which means that if you have that gene, you will have that dementia.
Yes.
And that's rare, very rare.
Like how rare?
I don't know exactly, but I'm going to say 1% or less.
That's what I've heard too.
For deterministic genes.
Right.
And then for risk genes.
And do you mind if I interrupt? Having these deterministic genes usually ends with you having a young onset dementia, less than 65,
often. Yep.
right?
Yep.
Okay.
Yep.
Sorry. Go ahead.
And then the other thing that we're thinking about is risk genes or genetic risk, and sometimes we call it polygenetic risk or polygenic risk, because we're talking about multiple mutations inferring some risk due to those mutations' effect on protein pathways that would lead mechanistically to cell death that progresses over time across circuits and causes a phenotype or a picture that looks like one dementia or another. And then on autopsy it looks like that. So one of those, the most well-known and the most potent, is ApoE. And so if you have two ApoE4 alleles, you're at some 8 to 12% increased chance of developing 8 to 12 times increased chance of developing Alzheimer's, particularly late onset. And only 2 or so, 3% of the population has two ApoE4s. If you have one ApoE4, you have less risk. It's something like 3 or 4 times.
Now, that 8 times increased risk, that is when you're looking at the risk in a vacuum.
No doubt.
When not considering the other modifiable risk factors.
Yeah, and it's also 8 times a very low number of people who go on in the grand scheme of things to have dementia or Alzheimer's. So like, let's say
just a little bit.
Let's say it's 0.7% of the world is living with a dementia right now, and some percentage of that is Alzheimer's, right? And so 8 times 0.7% is still a very small number. So it's not a foregone conclusion that if you have two ApoE4 alleles, that you are definitively going to develop Alzheimer's by any means. It puts you at an increased chance, but an increased chance of a rare thing happening.
Do you still have, I asked you how many people are walking around with ApoE4 genetic mutations?
2 to 3%.
2 to 3% of the population.
Yeah, that's the number I know.
Yeah, that's interesting. All right. Anything else you want to cover before we get into the young onset dementia paper?
We could look at some scans. We could do that later. What do you think?
Are you looking at just regular MRI scans? Or
Yeah, some MRI scans of Alzheimer, typical Alzheimer's.
Let's do it now.
All right.
Yeah.
So if you look, you'll see that this continuum paper back in 2019 that covered a series of dementing conditions and broke them down into reversible, irreversible, or progressive, and then looked at the imaging. This one is pointing out classic patterns of atrophy in a brain with that ended up finding Alzheimer's specifically. And so you can see the 2 arrows in A show what we call the hippocampus being in it kind of disproportionately and predominantly atrophied. And that's where memories are formed for recent events. And so that makes sense for the pattern of symptoms that we see in that condition. And then if you go back into the image shown in B, which is a side image of the middle of the brain, kind of looking in from the side, you see that there's atrophy maybe a little bit more diffusely at the midline, and then on C you see there's atrophy that's around the temporal lobes in general, and particularly at those medial temporal lobes, that middle part part of the temporal lobe where the hippocampus lives.
Mm-hmm.
And so this is a temporoparietal atrophy pattern.
Mm-hmm.
And that's classic for late onset Alzheimer's, which occurs after 65. There's tons of other things that can be shown on MRI that would help us to understand what that brain's been through and why the person might be having cognitive disability. And so it's not all Alzheimer's. Here I'm showing brain scans or MRIs from that same paper that show multiple infarcts or strokes. In this case, it's lack of oxygen strokes. We call that ischemic strokes.
Mm-hmm.
And those show up as these white matter spots or these little patches of cell death that show up as scars on one type of MRI scan in the white matter or the wiring of the brain.
Yeah. Real quick,
Yeah.
E, the middle one, is
Yep.
that a GRE sequence correlating to D, or is this a separate one?
I think these are separate people.
Okay.
I don't know that for a fact, but
The only reason is because I think the pattern that we're seeing in D is a lot higher burden, but sometimes there can be some non-specific changes that might look a little bit like D in what we would say is a normal brain.
Yep.
That hasn't suffered an infarct and hasn't suffered a stroke.
yeah, it's reasonable to take a tangent here. You know, I think we talked about this before, but as the brain ages, the smallest blood vessels that go to the most distal, smallest parts of the brain, sections of the white matter, give out and die off and leave a little scar. It's called a microvascular injury.
Mm-hmm.
And we see that in the aging brain. And there might be 2 or 3, 4 spots. They don't become confluent or coalesce and then take up a huge area of the white matter. If they did, it would be very symptomatic. So these are in the normal aging brain, silent, if you will. And that's to be expected, maybe a few every 10 years or so. And if you didn't see it, maybe it'd be surprising in a 75-year-old without any white matter spots, if you will.
Let me interrupt you. I've seen it in my younger patients as well.
Yeah.
Right. These kind of spots are significantly associated with people that have chronic migraines. Right. So sometimes we'll see these changes in people with chronic migraines.
Yeah.
What's your take on those spots and that kind of age demographic?
Yeah, I don't know. I don't know that science has determined yet what those spots indicate, whether they're microvascular infarcts having anything to do with etiology or the mechanisms of migraine or not. My guess is probably not. They're virtually silent. And so while people with migraine can have brain fog and cognitive disturbance related to the migraine phenomenon itself, they do not have a progressive neurodegenerative disease. These do not accumulate to a point where it looks like a vascular dementia where there's multiple of them coalescing and taking over big portions of the brain.
Is it injury to the brain?
I don't know.
It's hard to say, right? And some patients will ask me that, and it's difficult to answer. Yeah. And I give them the same answer that you gave, which is, we haven't seen this kind of progress and degenerate to, a dementia or anything like that. There's no specific injury that they sustain as far as a traumatic brain injury. Sometimes I just gotta shrug my shoulders.
Yeah. Yep.
Yeah. Okay. Back to this. Did you want to talk a little bit more about?
Yeah. So that middle image, E, is an image dedicated to looking at if there's ever been blood on the brain tissue itself through a vessel bleed or leak, either from trauma or from the vessel having a vulnerability. And so you can see here that there's both linear or zigzag kind of big black blotches or tubular looking pattern of blackness. And that's because there's been hemosiderin or iron deposits on the brain from blood leaking out of a blood vessel in that pattern. You can see little blebs or circles where there's been also a small microvascular bleeds. And that can happen in Alzheimer's, that can happen in somebody with a lot of vascular risk factors. And so that's what's shown here. And then the final image shows if that white matter injury becomes real serious, how all the white matter spots coalesce, creating this pattern of scarring that's typical of very advanced microvascular disease.
Vascular dementia, would you say?
Yep. Well, the dementia part is a clinical diagnosis,
Right, but
but this would likely be
yeah.
associated with somebody who's got cognitive processing, processing speed issues,
Mm-hmm.
and so a global appearance to the cognitive difficulties, and not a pattern that would be typical of Alzheimer's, for example.
And now, would you ever say, in the context of F, could all these be silent infarcts, or would you say, in all likelihood, and as part of even the diagnosis of a vascular dementia, they would have to have distinct strokes in the past as it relates to either hemiparesis or...
No. I think in this case, I'm seeing what I think is probably a larger stroke in the parietal cortex. I guess that's the left, based on this view. But I think probably a lot of these white matter injuries were silent and accumulated over time to a point where it hit a tipping point and cognitive reserve gave way, and that person became symptomatic and eventually had to see if they could control the risk factors for this: blood pressure, glucose, hyperlipidemia.
So potentially this could just be something silent that's happening over years, and then eventually they just start exhibiting the signs of dementia.
At this point, I would guess it's symptomatic, and I would hope
his dementia is symptomatic.
My guess is that this individual's cognition was not good at this point.
Right,
so.
But what I'm trying to delineate is, are there like prodromal actual stroke events that occur, or is this a silent process that can be happening that then the manifestation of which is...
I think it could be either, right?
Symptoms.
I think some people could have an accumulation of silent
like
microvascular disease or microinfarcts that are asymptomatic, but when they accumulate to a point that it slows processing, people around them say, you know what, mom is...
the brain.
Yeah, or mom's not functioning normally.
Right.
We get that she's aging 65, 70, and a little forgetful, but there's something that she's getting lost now, and when she comes into a conversation, she repeats herself, and you can find that she's maybe accumulated a series of strokes.
Awesome, this is great. Okay, anything else that you want to cover here before we move on?
No.
Okay. All right. So, do you want to bring up the paper on there too? Do you want to get into the young onset dementia paper?
Yeah.
And would you like to introduce it and maybe stress the importance of this paper as it relates to our understanding of the modifiable risk factors for dementia as a whole, but then also for young onset dementia?
So this paper came out in 2023, and it came out of a data set called the UK Biobank, which is a massive prospective data set, meaning collected from people as they age. And so the sample was of healthy people, mostly white, in multiple sites throughout the UK that were younger than 65. And the I think kind of hallmark of this study, the cornerstone of why it's interesting is a couple things. One, that it's a large data set. Two, it's prospective, collecting as we go, not retrospective, looking back at clinical charts and trying to pull from data that might not be perfect or only based on subjective report. And then three, that it's in young onset, which I kind of alluded to before, but young onset dementia is just a term that means a dementia that has been diagnosed under the age of 65. And so that population is smaller than the diagnosis of dementia after 65, which is a more typical age at which you'd see symptoms and make a clinical diagnosis of dementia.
Now, in terms of these being a neurodegenerative condition versus a reversible dementia, is that delineated in this paper?
So we're trusting that the diagnosis made by the physicians that saw these patients during the study and entered that ICD-10 or 9 code have made the diagnosis the way we just talked about.
Yeah. Okay.
So that they've ruled out reversibles and have made a diagnosis based on clinical exam and biomarkers.
Okay.
And so let's say that all of that was done well, reasonably well. This would be the first study of this magnitude that looked at multiple risk factors that had been proven out in late onset dementias over the age of 65 for years, but had only been tested piecemeal in smaller samples in younger populations. So, for example, ApoE4 has been tested in younger populations, and there's been some findings about risk there, or vitamin D, C-reactive protein, things like smoking and cardiovascular risk factors individually. Or in one study that was a little bit smaller, looked at 14 of these factors and tried to make sense of how they interact. But this study had a massive sample size that allowed them statistically to look at not only multiple factors and kind of have good confidence that these factors actually would be generalizable to other young people and young populations, but also how those factors interact with each other. And so I think we should probably come up with a metaphor or analogy to find why that's important. Maybe we can think about rebounds in basketball. If I could measure one thing to predict who's going to be the best rebounder, that's better than having to measure 2 or 3 things, right? And so who's going to be the best rebounder?
The tallest.
Somebody who's the tallest.
Guy, right.
Maybe somebody who's the tallest and reaches the highest. Maybe somebody's got longer arms and can reach higher even though his head height is about the same as other people. And so you might measure how high they can reach and how tall they are. But those things are going to be so correlated, it's probably going to be close to one-to-one correlation, right? And so I don't need to measure height and how high they reach, but I might measure height and vertical, how high they jump. Not everyone's jumping the same. And if some guy's very tall and jumps higher, he's probably getting more rebounds, let alone some other things that probably play into rebounds. So I might not measure 2 things that correlate so strongly with each other to predict the end outcome. And so in this case, they looked at the intercorrelations between tons of risk factors, 39 different risk factors that have been proven out in late onset dementia as risk factors, and said, how do those things interact statistically, and what's the best predictive model of the fewest items that I can measure that have the most potent effect on the risk for young onset dementia. And so they went from 39 through multiple models and iterations down to 15 risk factors. I think kind of, I don't know if we want to skip right to the punchline.
Yes, we do.
But
yes, we absolutely do.
But and we can kind of pick apart any other part of the paper. But the punchline really is figure 2, where you can see that there are a number of risk factors, 15 listed here, that have potent effects on the risk of young onset dementia, the dementia diagnosed after people entered the study healthy and were followed for years, and before the age of 65 were diagnosed with a dementia by a physician, and that was written in the chart. And so that was the outcome that they were trying to predict. And they found that things like education level and hand grip strength, which we can pull apart a little bit, and some amount of alcohol use were protective against young onset dementia, whereas things like C-reactive protein, a general marker of inflammation, or vitamin D level that was lower than 10, or the incident of depression or heart disease, diabetes, stroke, orthostatic hypotension, have low blood pressure when you get up, those things were risk factors. And if you look at a hazard ratio, you kind of start to think, well, what does that all mean? I'll just pick out a few that had pretty high hazard ratios. So depression had 3.25 hazard ratio. So it's 3.25 times the risk of having young onset dementia if you had depression as compared to not having depression. ApoE4, having 2 alleles of that, 1.87 times the risk. So less than depression.
Right.
Maybe that's a punchline in and of itself right there.
According to this paper, depression is a bigger risk factor for young onset dementia than ApoE4. Having 2 ApoE4 allele mutations.
Exactly.
Pretty incredible. What else? What one risk factor really jumps out at you here?
Well, the alcohol use one does, but that's because it's tricky, and we can kind of dig into that. But the social isolation is an interesting one. 1.53 times the risk of developing young onset dementia if you have social isolation. And I'll just pull up the way that was defined. I think that's important. So social isolation was defined as having contact with friends or family once a month or less, versus more than once a month. And so it was protective, obviously, if it was more than once a month.
Right.
And so that's a really rudimentary, kind of fundamental, basic measure of social interaction. Social interaction is a pretty complex thing.
Right.
We're calling people, texting people, interacting on social media. We're interfacing with people live.
And the dynamic of that social interaction.
Yeah. But at the end of the day, I think what science has shown us about social behavior and social isolation, or having social resource, if you will, or social capital, is that the feeling of loneliness, in fact, is the best predictor of bad things, bad outcomes, whether it be all-cause mortality or cognitive decline with aging, or risk or vulnerability to the common cold. The feeling of loneliness is a potent risk factor. Mm-hmm. And so I'm guessing this social isolation measurement is a proxy for kind of being lonely.
Yeah. My understanding is that loneliness is defined differently than social isolation, just because loneliness involves a specific feeling versus social isolation, involves just a context and an environment.
It could be correlated in many cases, right? Because some people who are isolated can feel lonely, and people who, have contacts, have friends and family they interact with on a regular basis can also feel lonely. So it's not a one-to-one correlation, but it's probably correlated.
Well, if it is, it's a big deal, because there's an epidemic of loneliness and isolation, and apparently about 1 in 2 adults in America reported experiencing loneliness. And I think that number was even higher. I think it might have been 50 to 70% in the teenage age demographic.
No.
So if we're looking at social isolation, potentially loneliness, as being a risk factor for young onset dementia, then we can think about how that's going to impact those populations from a public health standpoint.
And it's probably even worse. And I know there's data on this. I can't pull it up in my mind to quote a stat, but when there's loneliness in the context of dementia, in the middle of having the difficulties and deficits of dementia.
Exacerbates it. Yeah.
And so we should have a whole episode on it. I mean,
we are.
Part of my PhD was on social interaction and how that is influenced by brain structure and function.
Yeah. Can't not mention orthostatic hypotension, right? The hazard ratio is 4.2. It's the highest hazard ratio up there. What are your thoughts about it? My thoughts are orthostatic hypotension is very frequently experienced in the context of dementia as potentially a prodrome, like you would experience in Parkinson's dementia, or not. And there's a lot of reasons for you to have orthostatic hypotension that wouldn't necessarily be dementia. So certainly there might be some reverse causation there. What do you think?
Yeah, I agree. I think, they actually did a reverse causality analysis where they can try to understand in time whether one of the risk factors identified could have been actually caused by the dementia rather than a cause of, even though we're talking about correlations. This is one technique they use. And it was kind of a strength of the paper to put these risk factors through multiple subsequent tests, looking at the effects of age, the effects of ApoE4, the effects of gender and sex, the effects of time here in this case. And so it does look like from their analysis, it's probably a prodrome rather than a risk factor for neurodegeneration. It's probably part of neurodegeneration rather than a risk factor.
But let's just say, if your systolic blood pressure is dipping below 20 when you stand up, that's not a good thing, right?
Below 20? No, it's not a good thing.
I'm sorry. If you have a drop in systolic blood pressure
of more than 20.
Right, sorry, I misspoke. 20, definitely not.
Sure. If you have multiple episodes over a lifetime or over several years, the brain's not getting the oxygen it needs. Right. It's not going to be happy or developing the way it should.
And, then we start thinking about some of the other things: stroke, diabetes, heart disease, right? The sort of comorbid trifecta that we keep seeing as it relates to increased risk of dementia. I don't think that's very surprising there. Were you going to say something?
No, I mean, let's just look at the numbers, though. Stroke, 2 times the risk of developing dementia if you've got strokes. Diabetes, 1.65. Heart disease, 1.61. and so on.
Mm-hmm.
So, adding all those up, it's not good to have the trifecta cardiometabolic diseases.
Yeah. So all things that we should work on, definitely. Hand grip strength, protective. What do you think?
I think we agree. We've talked about this before. It's kind of a funny measurement, but maybe a proxy for the opposite of frailty, of strength, endurance, durability.
Mm-hmm.
Also maybe somewhat prodromal, as the neurodegeneration ensues, the individual might be moving less, might be becoming more frail,
Right.
and in so doing might have a lower hand grip strength. But there's been a lot of studies actually that show measurable and incremental gains in outcome mortality with increasing different types of strength, hand grip strength, leg strength. And so I think it is probably a proxy for being durable, for not falling, not breaking a hip, for withstanding everyday life in a way that doesn't put you at risk of other things that can cause neurodegeneration or death in that case.
Yeah. But, certainly this is a good marker for frailty and overall muscle strength.
Mm-hmm.
But, I walked into my office the other day and I saw my assistant doing, hand grip strength exercises. And I'm like, what are you doing?
Right.
And he said, I'm working on preventing my dementia by doing this hand grip strength thing. And, that kind of leads me to the next thing of, it's a great marker for hand grip strength. And I came across a study that looked at, I think, about 200 elderly patients and actually did like a composite comprehensive muscle scoring strength test for them, where they accumulated basically a bunch of muscles throughout their body and came up with a single score. And one of them was hand grip strength, but they also involved other muscle scoring.
Right.
And, they found that increase in 1 unit of strength in that composite muscle strength table decreased people's risk of Alzheimer's disease by 60%. Mm-hmm. Interesting. But what was also interesting was they factored in, okay, is this prevention of dementia just because of the hand grip strength that we measured?
Right. Because
they understood the correlation. So they took hand grip strength out, and then they found that axial muscle strength and all these other muscle bodies that they measured also contributed to the prevention of dementia. Cool. Which kind of tells us it's obviously not how strong you can grip something, but it's your overall muscle strength. I think.
Yeah. A couple other things to point out, I think, are things that didn't make it into the model. So it's not a perfect study. They didn't have perfect measurements for every single aspect, like sleep, for example. In sleep, they, first of all, didn't find that it entered the final phase of the model, but they weren't measuring probably one of the most potent risk factors related to sleep for dementia, sleep apnea. Let me kind of just look here at what they used to measure sleep. So they found that they had variables for never sleepless, sometimes sleepless, and often sleepless. And so a 0, 1, 2. And essentially, that's how they came up with sleep as a risk factor. And so that's not the best measurement of sleep. That's not maybe the most accurate way or detailed way. And so maybe that's why it didn't make it to the model. Exercise was similar. They had a proxy for exercise. Diet was similar. These are all things that obviously we know are important, but if not measured in a way that makes sense, maybe they don't enter the final model here. Or maybe they interact with these other variables in a way that the other variables are more predictive. Maybe exercise, diet, and sleep are really just mechanistically related to blood pressure, diabetes, and stroke that ended up making it to the model. Maybe those are better predictors. But we can't know just from this study alone. Just figured it's worth mentioning.
So what about vitamin D status? I think vitamin D deficiency is regarded as less than 20. There certainly seems to be some risk with the 10 to 20 range of vitamin D status, but it's most pronounced less than 10. What are your thoughts?
Yeah, that and C-reactive protein probably have something to do with inflammation in the body. Mm-hmm. Is it, a very specific marker? No. But is it worth considering in people who have an inflammatory profile? I think so.
Yeah, definitely. Anything else jumps out at you here?
I think that's some of the kind of high points of the finding. The rigor that they went through to ensure that the findings were not due to other factors like age or sex, for example, I thought were pretty strong. So, for example, they looked at not just age under 65, but also added people between 65 and I believe 70 or over 65 anyway, and tested, how that would change these risk factors, and or which ones were more potent in older ages versus younger. And so there's only a few, actually. Education ended up being more potent of a protective factor in later onset dementia. And then ApoE4 status. So both one allele and two alleles of ApoE4 had a much more potent effect on risk of late onset as compared to young onset. And so that was 2.67 times and 8.6 times increased risk for one and two alleles, respectively, for late onset versus in the 1.5 and almost 2 times risk for young onset. And the final thing is hearing impairment, which is interesting. We'll probably come back to it, but was more of a predictor of young onset rather than late.
Yeah. And you're right. We will come back to hearing impairment, and I was planning on bringing it up. Hearing impairment is a more significant risk factor than having one ApoE4 allele, which I thought was really striking. And I wonder what your thoughts are on this whole hearing impairment, social isolation, like the deprivation of stimulation, and how that relates to it being a risk factor for dementia.
Yeah.
It could be as simple and logical as like you don't use it, you lose it kind of a thing. But I'd like to hear a more eloquent reason from you.
I don't have one, man. I thought the same thing. If you don't have input, it's going to be very difficult for you to stimulate the brain the way that you would if you did have input. So blindness and or vision impairment and hearing impairment are definitely predictors of long-term cognitive difficulties in dementia.
Okay, this is fantastic. Are you ready to move on from this paper?
Yeah.
Okay. Now, what do you want to move into? Do you want to move into the next paper? Or it's not really a paper, but 2024 Lancet Commission report on the 14 modifiable risk factors for dementia across the board.
Yes.
Right? Not just late onset, not just young onset, but across the board, the 14 most modifiable risk factors for any dementia. And, well, why is it striking? It is striking because, I'm going to quote their statement, the potential for prevention is high, and overall, nearly half of dementias could theoretically be prevented by completely eliminating these 14 risk factors.
Yeah.
That's a wild statement. Not wild, but it's fantastic statement.
Well, yeah, I think it's hopeful, and it takes us from a place where I think we all have fears that get the best of us. We're at risk, our exposures, our environment, our genetics that we weren't able to control in some way are inextricably and kind of perpetually imposing a risk on us that we're never going to be able to overcome with lifestyle. But this suggests probably that's not the case. There's probably a lot we can do to prevent the onset of dementia, or at least prolong the onset of dementia. So make it come on later, or develop a cognitive reserve to the deficits and injuries that occur over a long period of time, so that we can maintain a healthy brain and healthy brain function over a longer period of time.
That's an important point. And the point that I want to piggyback on top of that I mentioned at the beginning is, even if you develop dementia by addressing these 14 modifiable risk factors, you could potentially be increasing the number of years that you'll be healthy with that diagnosis,
right,
and decreasing the number of frailty years that you have with that diagnosis, which I think is just as massive. Like, addressing these 14 modifiable risk factors might prevent the dementia, might ward off the diagnosis of dementia, and even if you get the diagnosis of dementia, potentially extend the healthy years that you can have with that diagnosis. So that's why I think these risk factors are just huge.
I heard someone talk about, maybe this will be better suited for when we talk about exercise, but what if, somebody approached you or a commercial came on the air and said, look, we've got this treatment and it could reduce your chances of having dementia by 4 times. It could improve your mood and improve your sleep and boost your cognition. It doesn't cost anything necessarily, and the side effects are as minor as a strained ligament or sore muscles. That treatment would go, like crazy anywhere you sell it.
Right.
If it was a pill. But that's exercise, in a nutshell.
Yeah.
And so we're talking about things that people can literally do, and we could all do more of. And so I think it's a hopeful note. And one thing that I think this new commission statement or report provides is another 5% on their equation from 2020. So 2020 is at 40% preventable. Now they're saying...
So contextualize that a little bit. They came out with a similar report 4 years ago, and
they said 40% of cases of dementia are preventable.
Right. And they provided how many modifiable risk factors?
It was less than 14. I think it was 3 less.
It was 12, I think. They added LDL cholesterol and vision. Was it vision loss? Yeah, they added vision loss and LDL cholesterol to this new commission report.
And so with that, they're gaining additional predictive power of who might go on to have dementia with these risk factors, and it's a helpful roadmap. And I think the infographic that's associated with the report kind of is a slam dunk for me. It's something I can use with my patients every day of the week. Pull up this image and talk them through. In fact, I use it for myself. I use it for motivation to think about what is it that I can do today or measure today to get a sense of where I'm at and what I can do to incrementally kind of pinch down on the risk or boost up on the potential for me to have a brain healthy life through my lifespan. Yeah. So if you look at that figure, it's figure 9. You can see up at the top there's an early life segment, and then the graphic takes you through kind of a timeline throughout the lifespan and when each risk factor might show up and be most potent based on the current evidence. And so in early life, less education is a potent risk factor, 5% increased risk, and then contributory to the risk of having dementia in any life.
Quick tangent on education. This is a factor that we see all the time come up in these papers and all these research studies, and even the young onset was a factor. Here it's a factor. Clearly, this is a huge factor when you're talking about the modifiable risk factor for dementia.
Yep. And I think at the end of the day, we're probably talking about proxy for access. Who has access to good education, has access to other good resources, and the finances to afford them the types of foods and exercise programs and so on and so forth early in life to make these things habits. But also it probably lays down framework for what we call cognitive reserve, which is the partially kind of fluid intelligence, or the ability to learn new things and become proficient and expert in things.
Are you aware of any ways to measure cognitive reserve yourself? If someone's like, hey, I want to know how much cognitive reserve I have.
It's a good question. No, I don't know. There's been some recent work looking at MRI to compare an individual structural MRI against a massive database of normal age and gender and demographic kind of normed MRIs, and you can create a brain age from that. I don't know if that's mainstream. I don't know if you could do that just coming off the street into UCLA to get your images. And I don't know cognitive testing wise whether you can claim a series of cognitive scores in a neuropsychological battery, for example, would help you gauge your cognitive reserve. But one of the things that we know boosts cognitive reserve is being fluent in more than one language. And so building that into your child's life gives them a leg up in a way against all things.
Hearing loss coming up again, 7% as a modifiable risk factor for dementia. We saw it in young onset dementia. But let's scroll down a little bit, because since we're talking about hearing loss, vision loss, 2% later in life. I mean, vision loss is something that's extremely common later in life. And it being a risk factor for dementia is new in this paper, and it's pretty striking.
Yeah.
What are your thoughts? Again, that sensory deprivation thing coming up again, right? Hearing loss, social isolation, vision loss. Yeah. And then, we can talk about olfaction and how it relates to dementia, but I think we'll table that. We'll leave that for a later episode. But
yeah, I don't know the mechanistic relationship between vision loss and its attribution to risk for dementia, other than just using common sense, not having an input there, and risking not having good visual acuity is going to cause accidents and other things related to worsened outcomes.
Yep. What else jumps out at you?
Looking at kind of the timeline of things, I think adds a lot to this picture. And then kind of putting on the map, which we talked only briefly about before, traumatic brain injury. It was actually in the young onset database, but they didn't have enough detail from looking through the medical charts if somebody had a traumatic brain injury and what type of injury it was, and so they weren't able to use that in their models. But here, clearly, there's been tons of studies that have said traumatic brain injuries of any severity, any number, have some can increase risk of dementia and neurodegeneration. Yeah. So that's important to put on the map. Those can be prevented or mitigated to some extent. Physical inactivity, this is a good one, brings up exercise. Inactivity, putting it that way. Right. You can think about sitting as the new smoking. Yeah. I don't agree with that, and I like, I think it's Dan Lieberman's view of that from Harvard in his book Exercised. I've seen him say, evolutionarily, we didn't run around all the time hunting. We sat a lot of the time, or they sat a lot of the time, except they just didn't sit for prolonged periods of time, 2 hours at a time, like we do in a particular posture. They got up frequently. Yeah. And so inactivity for a prolonged period of time is a risk factor. Diabetes, smoking, hypertension, obesity, excessive alcohol. Those are a little bit more obvious. Social isolation shows up again. Okay,
so we put all those risk factors together in midlife, and what's the aggregate of what we're looking like for the things that happen in midlife that dictate our dementia risk later on in life? What is that, 30%?
About.
That's pretty striking.
Yeah. Yep.
And I think it lends to the fact that
we can be doing things now.
Exactly.
In our brain health project at UCLA, the course that we're doing, where we're learning all about the reality of some of these risk factors and trying to decode some of the myths and trends and fads that are out there. At the end of the day, the young students are thinking, is this related to me and my life? Right. Can I do something now? Should I do something? Should I be worried about this? And I think the answer is you can do something now. Yeah. You could do something at 40. You can do something at 70 and still make incremental gains in brain health.
Well, they're undergraduates at UCLA, so they're definitely hitting the education piece pretty hard. Right. What else? Anything else jump out at you?
Well,
sauna.
Is sauna on that?
Sauna isn't on here, but I've been hearing a lot about sauna, about preventing dementia. It comes from a study out in Finland. I forget exactly what the N was, but it might have been 200 Finnish males. I think it was maybe a 60% reduction in people that use sauna 4 to 7 times a week. Right? Thoughts?
Sauna in isolation doesn't get at all of the other things that are probably related to somebody who can sauna, who can participate in an expensive act like that. So I think
because also people with heart disease are told not to do sauna, right? It's a risk. People can,
so maybe the individuals who are in the study don't have heart disease. Right, I don't know that study, but that's always what I'm looking for. And I think it's a good point is like, look, there's going to be a ton of new data all the time.
Right.
The skeptic, the good kind of reader of this information that's trying to be responsible about how they spend their money to get the most impact in terms of health gains is looking at that in the context of all things that have been done. And looking at that in the context of, well, what else did they measure? How did they sure this thing up? Was it just in men? Was it just in white men? Was it just, without looking at the effects of age or other comorbid conditions like cardiovascular or diabetes and other things like that? And so I think you always got to take those new pieces of data and put it to the fire and see if it holds.
Yeah, definitely. And these modifiable risk factors have held, right?
Yeah. This is an accumulation of tens of years of data.
As it compares to something like the sauna thing, this was done in strictly males, no females, and in a specific ethnic group, right? Whereas these modifiable risk factors are coming from a wide variety of studies and different populations, and obviously male and female.
Yep.
Yeah. So any more thoughts in regards to this?
No, I think that figure kind of says everything. We'll share that out, make sure everybody has access. What that makes me think of, I don't know if we're there yet, but is this brain scorecard, this brain health score that we can go through where we look at those risk factors in ourselves with anybody who wants to do it.
I would say if you look at midlife, the midlife risk factors, if you move your body, if you remain cardiovascularly fit and potentially decrease your risk of diabetes, you're looking at 2, 4, don't smoke, 6, and then 8% potential reduction in your risk for developing diabetes. And then hopefully that'll impact obesity too. You're looking at 8 to 9% reduction, which can be pretty robust. And that can also act on the depression piece, another 3%. So you're looking at, 11% reduction in your risk for dementia just by moving your body and trying to remain cardiovascularly fit. I really think that's a huge take-home point, at least when I look at this, in regards to modifying your risk for diabetes.
Yeah. When you talk about movement, I think it brings up this whole field that's fraught with fad, fiction, and some fact about extreme exercise routines.
Right.
And how do you know you're cardiovascularly fit? And does it matter that your aerobic system, cardiovascular system, and your anaerobic system, your strength, your durability, does it matter that they're both fit? And how do you measure those things? And so I'll just throw one tangent in there because we can hit it real quick and then table it for kind of an expert to come in and talk to us about it. But it's become popular science to talk about VO2 max testing. If anybody's kind of in the field of exercise or adjacent to it, they've heard about VO2 max testing and heard that is, New York Times said, the single most important measure of mortality and longevity. But the reality is the studies that have looked at cardiovascular fitness and how much that provides in gains for life and years and quality of years is not based on VO2 max testing. It's based on how fast you can get up on that treadmill during the testing before you quit. For example, this one study showed 4 times lower risk of mortality. Let me just rephrase it. 4 times higher risk of mortality for those people who were unable to get going very fast on that treadmill. They didn't test VO2 max, but 4 times increased risk of mortality is pretty high. So exercise is critical. And every increment you went from being low on cardiovascular fitness based on this test, which was not based on VO2 max, to being moderate, to being high, to being elite. Every step you took, you actually gained protection against all-cause mortality. And so it matters quite a bit. But I think you could probably measure this and simplify exercise and physical activity quite a bit just by thinking about cardiovascular fitness with METs. Should we do METs?
Yeah.
I feel like we should hit it.
Yeah.
So METs, or metabolic equivalents, of a task.
That's awesome.
Yeah, and so when that study looked, and we'll link the study at cardiovascular fitness or cardiorespiratory fitness, they looked at how vigorous the individual was able to ramp up their activity, and then categorize them as low, moderate, I think, high, and elite. And each of those categories had predictive value in all-cause mortality. Obviously, the lowest, the bottom 25th percentile in cardiorespiratory fitness, based on these measurements, had the highest chance of all-cause mortality, 4 times the chance. And they looked at METs. And so if you boil it down to what can I do at home to test myself, to see whether I have a cardiorespiratory fitness that is protective, and I'm not in that 25th lowest percentile, you look at what you can do on a regular basis and whether you can do that easier or faster. And so looking across the METs, light activities, METs 1 to 3, standing 1.3, reading, talking on the phone 1.5, walking slowly 2, cooking, light housekeeping 2.5, moderate activities 3 to 6, walking briskly 3 to 4, gardening 4, bicycling 6, vigorous activity 6 plus, running 9.8, swimming 7, aerobic dancing 7.3, and so on. So when you're in that vigorous plus category, you're on the higher to elite level, probably not elite until you get up to that level 12 maybe, but higher level where you're having significant gains in protection against all-cause mortality. And so that, to me, is simpler than thinking about VO2 max testing, and in fact is closer to the cardiorespiratory fitness that the study that we'll link actually measured to show that there's major gains.
Right. Yeah, this is fantastic. And it reminds me of the hand grip strength thing.
Yeah.
Right. Where it's, it's not how tightly you can squeeze something. It's a measure of something else that involves a lot of different things.
Multiple factors.
Right. Exactly. And even frailty, I think you need to meet, in order to meet the criteria for frailty, you need to meet 3 out of 5 specific criteria, phenotypic criteria, one of which is low grip strength. The other one is low energy, slowed walking speed, low physical activity, and/or unintentional weight loss, right? So it's not just hand grip strength. It involves a lot of other things.
Yeah.
Okay. Do you want to take this test now?
Yeah.
Yeah.
One thing I'll just say is, look, we could break down every single one of these risk factors and have an entire series on each one. So to kind of synthesize everything we just talked about and write recommendations or kind of talk about guidelines or protocols or stacking some habits to get there, I think we'll get into that. Maybe we just take the test. That in and of itself causes us to think about our habits and what could be done to improve, because it's pretty actionable. So I'll intro it. It's the McCants Center for Brain Health, which is an MGH-based center for the Brain Care Score. There's tons of brain health assessments out there. A lot are garbage. This one is in my mind evidence-based. In fact, there had been a study. Also, UK Biobank was the sample, and they found that if people increase their score just by 5 points on this 21-point score guide that we're going to look at in a second, they could reduce their chances of dementia and stroke by 60%, up to 60%. And so that's a major thing. We're talking about adding up all those percentages in midlife of improving on some risk factors. If you can increase your score, and we're going to look at how can you increase your score. What bringing blood pressure down from what to what gives you a point, and so on. So I'm going to do this live right now. I'm going to check my score. And I've done this before, so I'm a little embarrassed, but my score is not great.
What is it?
Well, it's 13. I'm just going to tell you right off the bat, but let's go through it. So
I'm doing it now.
All right, cool. So what we see is the first category is your resting blood pressure with or without treatment. And so I'm going to throw out there that I haven't gotten a blood pressure very recently, but I've never been hypertensive. It's 120 over 80 or less. So that awards me maximal points. And the more points, the better on this scale. Your hemoglobin A1C, or how often your blood sugar is above normal over 3 months. It's a rough average of that. I'm less than 5.7, which puts me in the non-diabetic category, and the categories range from 5.7 to 6.4 and above that. And so I'm going to get maximal points for that. And then your cholesterol level. I'm not on treatment, and my cholesterol is below 190. And so that benefits me as well. And then obesity. I don't know my BMI, but I'm going to put myself in the obese category just based on that. And so let's see where that puts me. Then recommended dietary habits include, and it lists out all these dietary habits, which I think is actually a reasonable framework based on everything we just talked about with Tim Spector and Federica Amati recently on previous episodes.
Yeah, and dietary habits are so difficult to look at, especially in this kind of UK Biobank and these kind of studies.
Yeah, looking at subjectively reported things that have to do with the bias of remembering and reporting honestly is fraught. But for myself, do I have 4 to 5 servings of fruit and vegetables per day, 2 servings of lean protein per day, 3 or more servings of whole grains per day, less than 1,500 milligrams sodium per day, less than 36 ounces of sugar, sweet beverages, soda, juice, etc. per week? And so let me say the answer choices are fewer than 2 of the recommendations above, 2 of the recommendations above, or 3 or more. So I'm just going to throw out there 2.
Okay.
See where we're at. Alcohol consumption. We're really getting personal here. So 4 or more drinks a week, 2 to 3, or 0 to 1. The studies that looked at alcohol, particularly the young onset one that we went through, categorized it as 0 or abstinence. 0 to 1 for women, 1 to 2 for men was kind of a 1 level risk, and then a 2 was more than 1 for women, more than 2 for men. So anyway, for me, I'm probably at 4 or more per week. And then smoke cigarettes. I never smoked, so I'm going to put that. Aerobic activities, less than or more than 150 minutes of moderate or 75 minutes of vigorous. So that goes back to those METS categories that we talked about.
Yes.
And then sleep habits, untreated sleep disorder or treated sleep disturbances, and at least 7 hours of sleep per night. So I have at least 7 hours. I'm not treated. And then your stress level, high level of stress, moderate, manageable. I'm going to say moderate. 3 kids.
Lucky you, buddy.
Work. You're at high?
I'm at an all-time high these days.
All right.
Okay.
And then social relationships. I have few or no close relationships. I have at least 2 people. And so I'm going to put 2 people, and those categories include spouse, children that I'm close to and I can talk to.
I like this last one.
Meaning in life. I do too. I think this doesn't get, I was actually talking to somebody who lost their home in the fires recently, in the Palisade fires. And he said, you know what, I think meaning in life, because we're going through this scale for the warriors that we treat, meaning in life is underrated. It should get more than 1 point. And I agree with him.
Yeah.
I often struggle to find value or purpose in my life. I generally feel that my life has meaning and or purpose. So I'm going to say the second one. And I'm going to the next page. Hope you guys are doing this with me.
Yeah, I'm doing it.
And then I get my score. It's 15. Okay, I kind of, maybe I was a little more lenient towards myself this time around. Yesterday when I did, I got 13. So then it gives you some recommendations about how to improve, and it's linking you off to, the government sites like CDC, WHO, American Heart Association, some stress management programs.
But you get your score, and does it tell you anything about your risk for dementia at that score?
So we know that if you can improve that by 5 points, and you're under 50 years old, you can drop your risk of dementia by almost 60%. So I'm looking for 5 points on that scale.
Okay.
Ways that I can gain 5 points.
Okay.
That's my objective. That's the way I'm reading this based on the evidence.
That's super interesting because it's not necessarily meeting a specific score, but rather, just completely goal-oriented in terms of it being for yourself.
The most actionable thing I've seen out there.
Yeah, that's great. That's fantastic. And we will link this in the video description. All right. Amazing. Did I already say that I scored a 17?
You got a 17?
Beat you out, buddy.
Damn. I got to get to the gym.
Yeah, I think I was pretty honest. And you really want to be pretty honest with a score like this, right? Because, it's just relative to the score that you initially score.
Yeah.
Okay. Anything else?
I think there's got to be a healthy skepticism for trends, fads, and fictions that are out there for influencers that are selling product. We'll have a whole episode, if not more, on supplements.
Yeah.
It's a difficult market to get a handle on, and I think people should be skeptical.
Yeah. My sense is that this episode that we did, by no means are we diving into these individual modifiable risk factors. It was really an introductory episode, I think, into all these modifiable risk factors and really laying the context down for why it is we're going to individually go into these risk factors. It's because when you put them all together, potentially we could be looking at, cutting out 50% of the dementias out there. And that's why it is that we're doing what we're doing. So that was the purpose of this episode.
Yep.
Do you want to add anything?
I think it's a hopeful message, and I think there's a lot to do, a lot to learn, and when we bring other experts on the podcast to talk about each of these areas, we'll be able to ask all the questions that the viewers have, all the questions we have, and try to dig down what is the most accessible and accurate and actionable thing that we can pull out of each domain. Exercise, nutrition, sleep. There are questions that are extensive in each area. The data and the publications are extensive. What's the latest, but also what's the most reliable science in each of these areas, and what can one do that's not extreme, that's not fad-based or some kind of trend that only people who are in the elite in terms of financial or athletic that everyone can do.
Yeah, definitely. Anything else?
No.
All right. Thanks, buddy. That was great.
That was great.
Yeah. All right, everybody. Thank you for joining us. The Better Brain Podcast. Just remember, be better.